Hello, and thank you for attending the 2026 Protocol Update Training. My name is Dr. Tom Charlton. To align with the introduction of the LifePak 35 and its ability to perform 15-lead EKGs, the term 12-lead EKG was replaced with diagnostic EKG. We have several new protocols to discuss. In an effort to better prioritize immediate actions in critical patients, crashing patient was added. Based on other success around the country, we added an opiate withdrawal protocol so we can treat patients immediately, protecting them from another overdose and connecting them with long-term treatment. In a major development, blood and blood product administration protocol was added. This capability enables departments around the region to begin carrying blood and blood products for EMS initiation. Our last new protocol is ventilator sedation. This permits sedation following intubation, facilitating safer transports for our more rural agencies. There are numerous updated protocols as well. Let's start with the new protocols for 2026. The crashing patient protocol was developed off of several other similar protocols around the country. Other protocols have shown improvement in outcomes following initiation of this prioritization. This protocol is intended to emphasize certain assessments and interventions that are high yield for the actively crashing patient. Some of these actions ideally are accomplished prior to movement and/or transportation. The protocol emphasizes airway interventions such as CPAP, bronchodilators, and bag valve mask ventilation. It also recommends early and frequent vital sign monitoring. Early IV or IO access is also emphasized, allowing us to treat shock before moving the critical patient. When dealing with a crashing patient, it is imperative that the patient is kept on monitor until they are moved to the hospital bed. This protocol means that when we encounter a critical medically ill patient, it is sometimes better to stabilize in place quickly and then move them out to the truck. Our new opioid withdrawal protocol has enough training requirement that we are breaking this off of our normal protocol video. Agencies choosing to adopt this protocol will need to refer to that separate training. The blood and blood product administration protocol also requires separate training from the overall protocol training. Each agency may have different procedures and policies on the administrative aspects of blood product administration. Therefore, each agency is responsible for training their staff. If your agency provides mutual aid to a blood product carrying agency, it is important to review this protocol and that agency's associated training. The sedation after intubation protocol was added for next year, permitting us to treat resulting pain and anxiety following intubation. This sedation is only permitted following orotracheal intubation and not supraglottic devices. The protocol permits the use of midazolam or ketamine based on parameters on the next slide. It is important to document the patient's level of consciousness and pain levels before and every 10 minutes after administration of the medication. When handing off care to the hospital, please inform the staff of the medication used, when it was given, and how many doses were administered. In patients with a systolic blood pressure of greater than 100 and less than 150, either ketamine or the combination of an opiate plus midazolam may be given. In patients with a systolic blood pressure greater than 150 or at risk for hypertension, such as stroke or stimulant overdose, the paramedic has the option of midazolam plus either morphine or fentanyl. In patients with a systolic blood pressure of less than 100 or at risk of hypotension, such as trauma, sepsis, asthma, ketamine is preferred. Ketamine may be used with push-dose epinephrine in this population if needed. Now for the updates. The cardiac arrest protocol had a significant update. As pre-hospital care of cardiac arrest has improved, it has created a new phenomenon. Our CPR has gotten good enough that in some patients, some degree of consciousness may occur with the improved cerebral perfusion. These patients may exhibit extremity movement, attempt to sit up, make purposeful movements, develop a gag reflex, and may vocalize distress. Despite these findings, continue to provide CPR. At the next rhythm check, if these signs cease when CPR stops, this may be CPR-induced consciousness. If you encounter CPR-induced consciousness, paramedics may administer midazolam, 2 to 5 milligrams IV or IO, every 10 minutes if this consciousness interferes with CPR. In some cases, restraints may be needed. Our post-return of spontaneous circulation care had a few updates. Goal end tidal capnography target is 35 to 45 millimeters of mercury. However, that is only after effective circulation is established. Once the patient's perfusion and ventilation are stabilizing, providers may begin titrating ventilations to this goal. A reference was also added to the new sedation after intubation procedure. In the continuing evolution of our restraint protocol, a new method of assessing levels of agitation was added. The Richmond Agitation Sedation Scale, also known as RASS, has been used elsewhere in healthcare for some time. This takes our previous observations and provides an objective score that can guide treatment. Patients with a RASS of 0 are alert and calm. Patients exhibiting restlessness, anxiousness, apprehension, but movements are not aggressive or vigorous are a +1. Patients with a RASS of +2 are now more agitated, uncooperative, may resist care, and have frequent non-purposeful movement. A patient with a RASS of +3 are pulling at equipment, may fight their environment, cannot focus, and are very agitated. When patients become combative, violent, and present an immediate danger to the staff, they are scored a +4. Now that we have an objective score, we can more easily titrate our treatment to the patient. In all of these cases, if you have a smaller adult or an elderly patient, the dose may be reduced if needed. For a RASS of +2, these patients may be given midazolam 5 milligrams intramuscular. For a RAS of +3, midazolam is now 10 milligrams intramuscular. In patients with a RAS of +4, those that are in immediate danger to staff, ketamine at 4 milligrams per kilogram ideal body weight, or as indicated in the dosing chart, may be administered. It is imperative that you document a RAS score in your report if chemically restraining a patient. A new flowchart has been added on how to care for LVAD patients in the unresponsive VAD patient. It also includes the VAD coordinator's number to assist in management. An important point is that the flowchart only applies to adult patients. For pediatric ventricular assist device patients, please call the children's VAD team. The eye injuries protocol had some language clarifications. It now also spells out that the irrigation should occur for at least 15 minutes. And that concludes our 2026 protocol training. Thank you for your attention. If you have any questions regarding this content, please reach out to your medical director or your normal chain of command.